Lori Batchelor, Arkansas Children's Hospital Director for Primary Care Services. Is there going to be a minimum number of patients for an individual PCP or a group practice PCP?
Okay.
Okay.
Hey, Sheena. I don't think you fully addressed Cheryl's question about specialists, like how you know how the primary care provider would know about the quality of the specialists or the cost that the specialist generated. And I would kind of extend that to other providers like CHMS centers and RSPMI providers.
Paula White, UAMS. Question, do you foresee a reduction in administrative requirements, such as, let's say, benefit limits, so that the PCP is the one that makes a decision on what is best needed for that patient and manages that referral process?
Question. Nikki Hilliard, College of Pharmacy. I had a question of whether pharmacists would have access to the SHARE program where we could add immunizations and glucose monitoring and blood pressure and medication adherence and all that information into the medical record, and how you see them as being a part of the medical home.
And I'm Dr. Jim McDonald. I'm the Vice Chairman of Radiology at UAMS. I have a question for the panel. I don't want to intrude in a primary care discussion, but I can tell you that it was, I can speak for all the radiologists in Arkansas that we don't like National Imaging Associates any better than you do. And it seems that the computer platform, the portal, might be a brilliant way to offer decision support to the primary care physician. Of course, radiology, Bill Golden has endured a discussion with me about this. The American College of Radiology has developed very robust appropriateness criteria that are available as a computerized plug-in for the EPIC system that we're installing, and I'm sure other specialties have done the same. I'd be interested in the panel's comments on the potential for that.
Go ahead and hold from there and take a few more. I'll go ahead and follow up with Dr. Ochoa and Cheryl's question earlier about the specialist referrals, or referrals to specialists and specialist care. Right now, I'll say that Medicaid does report on total cost of care how much your panel as overall spends on, say, CHMS or DDTCS, but we really, our vision is to become much more sophisticated in providing primary care physicians with information about how those individual practices, I mean, that is the vision, Dr. Ochoa. We're not there yet, and I don't know that we're going to be there for the first, the initial launch of PCMH, but it's a critical component like Dr. Thompson spoke of earlier. We know that without empowering PCPs with the information that they need to manage total cost of care, that it's really going to put us in a bind.
Sheen, if I could just add, and as an example, for those of you who have not seen the reports for the episodes, it's very different information, for example, that an orthopedic surgeon now gets for hip and knee replacements. It's 30 days before and 60 days after. Is that the episode? I think depends on the episode. But where Steve and Blue Cross, Medicaid, others have given the surgeon his or her specific information in the past, but not what happened before or what happened after. These reports are now about the complete episode of care. It is going to require more transparent information to be available for the primary care provider, which you've not had before. And we're going to have to navigate through the provider community to help make that be safely available, accurately available, and useful for you in managing the patient's total experience.
There was a question from Children's Hospital about the number of patients. And you caught me because, you caught me because I had on the slide something about pooling. And when we start looking at total cost of care, we have two challenges statistically. One is to make sure it's actuarially sound, so that we're not rewarding people for just random behavior. And the other is to be protective to the practices, to make sure it makes sense, because the law of small numbers, you don't really know. As the numbers get smaller, it's harder to understand what you got. So we have looked at the fact that it's going to probably require for each payer, about 3,000 to 5,000 patients to have a stable number. And I can't tell you exactly what it is right now. So it may mean that a large practice like Children's may have that many, or may have to team up with someone, or a number of practices may have to team up, or a system of clinics may have to go in together. But it will not be, the gain sharing will not be based on 100 patients in a single practice. So unfortunately, that's the rule of life with small numbers, and that will create new ways of relating to each other in the community, but also new ways of organizing services, either informally or formally in people's communities in the state.
Larry Simmons, Children's. With regard to the panels you just mentioned, will that be panels from all payers, or a 3,000 to 5,000 panel per payer? Because that's going to be a critical equation.
It would be per payer. The way we have set up and the way our great country runs, each payer has to be independent in how they manage the programs. Otherwise, we'd be having a little dispute with the Federal Trade Commission. So we have general frameworks, but when it comes to thresholding and payment rates and this kind of pooling, we have to do it per payer.
So the way other states have done that is you remember that $120,000 per year that Bill referred to? They give that to a managed care company because they can handle risk, and they have hundreds of thousands of members. And we're trying not to do that. We're trying to put the investment where the investment belongs. We're trying to reward and pay for outcomes for the individuals who actually are responsible and help produce those outcomes, not the company, but the provider. The laws of mathematics mean that we can't do that with individual singleton docs. The panel sizes just aren't big enough. So we pretty much have this either-or choice. Do we establish a system? Clearly we prefer this to be voluntary, and that is the plan, where you partner together to build those panel sizes across providers to a point where you can actually accept. Really, it's just upside risk in this case, and we can accept what amounts to us as downside risk if we overpay you for things that really are just random variation. It's an either-or choice. And in fact, the legislature considered a very strong counterexample to the patient-centered medical home in the last month, which was more or less the other way. So we have fought very hard and have expressly the intent of attaching the outcome to the person who helped create it, and yet we can't do it at the singleton level. So it's awkward, and we know that this is a change, but we feel like that the payoffs will be worth it, and want to work with you to help you with those establish those relationships with your peers.
Build off of that, in some of the modeling that the team has done, there are clearly practices that meet minimum numbers in and of itself. You have a 10-person, 5-person practice. You have plenty of members in your panel to meet a minimum threshold. For a more rural setting or more isolated providers, you may have to pair in a community. You may choose to pair with other providers that use the same electronic health record, so you learn how, the tricks of using that for each other. But the voluntary aspect that Andy alluded to was to let providers find who they wanted to work with, so that it was not a top-down, you will work with these people, but it was a bottom-up. Who do you want to work with so that you learn? It may be your classmates you want to pool together with. I can't imagine that working too well, but anyway, to leave it open for individuals to figure out how they would want to pool together.
Let me clarify. In the pooling, you don't. If you're a pediatrician, you don't have to pool with a pediatrician. You could be with adult care providers, as long as you get to the threshold, because you'll just get the risk-adjusted numbers. So it's not necessarily specialty specific. So.
Let me address, if I could, I guess part of the issue is commingling of dollars. We really can't commingle dollars, and that's why it's a per payer kind of requirement. Let me address the question about reduction in administrative requirements. And from a private insurance perspective, we put things in like pre-authorization and benefit limits and coverage policy and different things like that because we own the risk. And it's incumbent upon us to try to manage that risk to hold premium payments or premium amounts for our members to an affordable level. This is the beginning of transferring at least performance risk to the delivery system. So if you have a situation where you actually are participating in risk, and this may apply right now more to the episodes than the discussion about medical home, then we can begin to have discussions about, well, you know, if you're at risk for overutilization of high-tech imaging, then you can have the decision of whether we administer a high-tech imaging review program. So as we begin to see risk transition from insurance companies, especially performance risk meaning the variation in cost for a similar episode resulting in different costs, then we can begin to have discussions with you about eliminating some of the mother may I administrative kinds of limitations in the program, and hopefully we'll be able to do that over time. The other thing that I wanted to mention is from a private insurer's perspective, one of the things you need to understand is there have been people that have been trying to create integrated delivery systems to take the cost of care out under the fee-for-service system. What that really does is it ends up in very successful programs to reduce cost and create efficiencies with no rewards for the delivery system. In other words, they create efficiencies at their own expense. If you understand anything about the Accountable Care Act, there is a provision in there called the minimum medical loss ratio that says that if insurers don't pay out a minimum of 80 or 85% of every premium dollar back to the premium paying customer, then the insurance company has to rebate those dollars back to the premium paying member. And I'm not saying that's a bad idea. Regulations of insurance is a good idea. But what I am saying is if you do a good job of holding down medical costs and create a situation where the insurer has a lower than minimum medical loss ratio, yeah, that member is going to enjoy getting a check for $20.46 at the end of the year. They probably won't know why. It's probably not going to change their behaviors. By sharing savings with the delivery system, it allows us to meet the minimum medical loss ratio and actually reinvest those dollars into the delivery system to try to reward changes in behaviors that get us all to where we want to get to.
Let me pick up on Steve's because this risk issue is usually foreign to us clinicians. Insurance companies have a risk that they bear and that they're paying the premiums. What I think is different in our Arkansas Payment Improvement Initiative than almost any other that we've seen is that the payors, whether it's private sector or public sector, are maintaining the actuarial risk, the chance that I'm going to have a heart attack tonight. They're keeping that risk. They're asking to partner with the clinical lead, either on the episodes for an acute investment of resources or in the primary care setting for the long-term management. They're asking to partner with the lead clinician to manage the clinical management risk. So the actuary risk, the chance that I'm going to get struck by lightning or struck by a bus, is retained at the insurance company level, but what the clinician is much better able to manage, the clinical team, that performance risk is transferred, and with that comes gain sharing if the team performs well. So this is a very different thing. Andy alluded to a while ago what Medicaid managed care or private sector, they transfer all of the risk, and then you get an administrative layer laid over the clinical performance to try to micromanage what we do as clinicians. This is actually trying to partner with the clinical team, either on the episodes or in the primary care arena, to actually do what we should be able to do better than Andy on Main Street or Steve on Gain Street here in Little Rock from a centralized command post. So that's the...
There were three other questions. Let me see if I can do them very, very quickly. Do we expect that administrative management that is top-down bureaucratic, you can't do this because we just don't want to spend the money, prior authorizations, et cetera. Yeah, that is explicitly our goal. And we'll be looking for those, for the removal of, the handcuffs as, what would be, help me finish this analogy.
As you're freed.
For the next town hall, I will finish that analogy. Yeah. And so, and I'll move on. So, do pharmacists have a role? Yeah, we think that pharmacists have a role. Really, it's the same answer as with chiropractic. We're putting money on the table for outcomes, and we do not expect that MD physicians can do this on their own, but we are putting them at the head of the team as the current scope of practice dictates. Then, will they have access to information? That's a really good question, and we ought to come back with an answer to that when we have one. Portal, the decision support radiology. So could radiology algorithm, would those be helpful? Would they be available to clinicians? So I think that's a great idea, and the only question is that something we provide through SHARE for all primary care, or is that something that the vendors that we're currently qualifying will provide directly to clinicians on their own? And we may not yet know the answer to that, but great feedback.
Let me come back, Nikki. I think we didn't quite. Pharmacists now can connect to SHARE. There's no, any clinician can connect to the secure health information exchange. The funding that came with this American Recovery and Reinvestment Act did not include every clinician. So I think two separate questions. We have primary care clinicians that are getting funding to adopt electronic health records, and as a part of that funding are required to connect to SHARE and demonstrate meaningful use. Any clinician can connect to that secure backbone. And in fact, many of our specialists, UAMS here on OB services, high-risk OB, has dramatically reduced their paper faxes by being able to send secure messaging across the information exchange.